YouTube stream?
Yes, it's coming live in 1 minute.
Okay, it's already there. Yeah, thank you.
Hi, Mitu.
Namaskar, Mama.
Vallachu.
Namaskar, Kudi. Oh, Anji Appa, namaskar.
Yepa, namaskar.
Kieta, kodu achu tu tunnu.
Agya.
Vallachu.
Valla.
ये तुम कोठी बसिच टेंट को टेंट तले
का को कहउछु मते कहउछु मिता
राजेश्वरी को बसंती ना
गाड़ी भितर बसिछि ना टेंट रे बसछु
वो हम लानाई रे बैकयार्ड
oh
Must be nice.
अरे बाबा रे बाबा
You have to come, Jepa.
ओलो
All of you are welcome.
जिबी परा सरी गला मुखा सलीले जिबी
हां हां
के कोडी के एटा
नळी आंटी
निया और नित्यानंद
अच्छा काई के एटा होची
मु जानि नि मु किंतु देखि पार झुन्नो पा नमस्कार from Arizona
अंजना चौधरी
आरबाळा मिश्र
मिता तो भल अछि सुजाता को देखुची एते झड़ी जाईची सुजाता बहुत झड़ी जाईछु नलिनी बढ़िया था हमर सब वीक रे देखा
नमस्कार
नलिनी पर नमस्कार
Actually, I really didn't know who is Chandan Naik. Looks very young.
Here I am.
No, today, Anjapa. Another few minutes.
Kuku namaste.
Namaskar, namaskar.
नमस्कार
Go well stand it.
Anjapa, you probably know his parents.
के कहलु
Pushpa Naik and Parikita Naik.
Jonathan, I'm sending a message to your parents. They're not on yet.
Already Chaudhary.
Oh, okay.
That's this Chaudhary. Okay. So you sit here. Yeah, hold on a second. Hold on.
You can see a chart.
कस्तूरी कस्तूरी थाल भल छु दुसु तू समस्त ने एक्साइटेड टू हियर
मितु
नो both
and चंदन को जानी नहीं
से तो कहली ना we don't know Chandan I don't know
We'll know him pretty soon.
You may know my parents.
Let me tell you, she's great.
I can introduce that later.
yeah
Okay.
no problem is it time already
Jonathan, how does it feel having to be identified by your parents still?
Oh no, it feels fine. I'm used to it.
No, yeah, but that's the reason I did not want to put there that he's the son of so and so. So
no he has his own identity
I do have my own identity.
yeah कुकुट के चाट
It's already 1 or 2.
मु टिके देरी वेट करबे ना कोन करबा
11 o'clock हे गला
को पठौची मैसेज कोन पई ताप्ती
But since you are ODS, so we all claim that we are you are us. I think.
So if
Wait for a second.
Hi, Nita.
Hey, नमस्कार खुड़ी कोडे मु देखि पानु तुमको
काई मोडा देखा मो दुसु निलो
The camera on करनांती बोले.
चिन्नु लो कैमरा डाउन कर
अच्छा
खुड़ी स्निग्धा
Yeah.
Hey, Mom.
हाँ दिसला.
बर्तन दिसला
Sorry, not able to take a call right now. Send me a text message. I get them.
ओरे स्निग्धा
Is next to Kukunani.
हत
Oh, Smita. Sorry, Yara. Okay, yeah. Where is Smita?
कस्तूरी हेलो
नमस्कार
पहुंची गली नहीं सुनवार लगी समस्त को
केते देरी रही बा
this is definitely a needed forum our topic today
केते गोटे फोटो उठिया
Carry.
आज्ञा
Nita
Yes,
ମୋର
sir.
ଝିଆରୀ।
हाँ
Chandan is saying happy
Oh,
Women's Day.
Jitu.
Thank
Jitu.
you.
ସମସ୍ତଙ୍କୁ ନମସ୍କାର।
ନମସ୍କାର।
ସରି ମୁଁ ଆଉ ଗୋଟେ ମିଟିଂ ରେ ଅଛି
ଚନ୍ଦ୍ରାପା
ସେଥିପାଇଁ
ନମସ୍କାର।
ନମସ୍କାର ନମସ୍କାର ସରି ମୁଁ ଫଟୋ ପକେଇଛି କାହିଁକି ନା ମୁଁ ଆଉ ଗୋଟେ ମିଟିଂ ରେ ବି ଅଛି ଏକା ସମୟରେ କୁକୁ ସବୁବେଳେ କରୁଛି ଯିଏ ହେଲେ
ଆଜି
କରୁଛନ୍ତି କୁ ନୁହଁ ସରି
ଆଜି ତ ଗୀତ ବି ମିସ୍ କଲୁ
ହଁ ପରା ଗୀତ ବିବେକ
चंद्ररानी कुमार भंडारी कुमार
ଆରେ ମୋ ବିବେକ କେତେ ସୁନ୍ଦର ଷ୍ଟୋରି କହିଥାନ୍ତେ ସେଠିକି ଯିବି ନା
ସେଇଆ ପରା
ସେଇଆ ପରା।
I did not advertise
ହରିମନଙ୍କର ଗୀତ ଷ୍ଟୋରି ଆମେ ଶୁଣି
ଆମେ
ପାରିଲୁ
ସମସ୍ତେ ଆଜି ମିଠୁ ଆଉ ଚନ୍ଦନ କୁ ଶୁଣିବା ଆଜି ରେଡିଓ ପ୍ରୋଗ୍ରାମ
फ्रेंड्स
ଥାଉ
मान को कह।
ବନ୍ଦ
ଆରେ
କରିଦେ ଆଜି
କିନ୍ତୁ ଏଇଟା
ରିପିଟ୍
ଭଲ
କରିକି ଶୁଣା
ସବଜେକ୍ଟ
ओके थैंक यू।
ନାଉ वी कैन स्टार्ट
ଓକେ ଚିନୁ ବସ ରହ ଠିକରେ ରହ ମୁଁ ଗୋଟେ ଫଟୋ ଉଠେଇବି
ମୁଁ ଟିକେ କହିଦେ ସମସ୍ତଙ୍କୁ।
ଉଠିଲା ଫଟୋ।
1 2 3
ତମେ ଉଠେଇଛ ମୋର ଭଲ ହେଇଥିବ ଟି
Thank you ଅଞ୍ଜୁ ଅପା।
लॉर्ड हैव मर्सी
नितानी आरंभ कले हबो बोधे
हां मु जस्ट कॉल करची just to see if they join. Some of them have joined through YouTube.
Hi Siti
Hi. Mama, mine, no long time no see.
हाँ
I'm not here to take your call right now, but leave a message and I'll get back to you as soon as I can. Thanks.
Hi.
At the tone, please record your message. When you finish recording, or one for more options.
Hey Nutan, this is Nita waiting for the Kaveri group to join. Bye.
let me inform that
कौन करिबा रे?
उत्कल उत्कल हमर पोस्ट करिछ कि काहे कि दौनी हमको अलाउ करनी म्यूट पिछु
Okay. You more YouTube. I don't know what about others. No one else joined.
There are 5 people on YouTube, so we can start.
co-host
से करना दी काहे हम वी हैव टू मैनेज काहे ना कैन यू आल्सो एक्चुअली म्यूट कर देबो कि हमें आरंभ करिया गुरु समस्त म्यूट कर ली तापर जी
Hara baby.
actually
ଏବେ ସମସ୍ତେ म्यूट ରେ ଅଛନ୍ତି ଯେ କହିବେ ସେ କେବଳ ଅନମ୍यूट କରିକି କୁହନ୍ତୁ।
कौन करिबा स्टार्ट करिबा?
हां नीता पर लेट्स स्टार्ट टाइम
Namaskar, namaste, good morning, good afternoon. This is the 4th seminar presentation organized by OSA Women's Empowerment Forum. We have seminars every month on various topics. This seminar is breaking the barriers of mental health. I am Dr. Nivedita Mahanti, who is going to introduce the topic and the speakers. Dr. Chandan Naik, Dr. Smita Das. From Middle Ages, doctor means a learned person or a teacher. We guide, help, advise a person to heal thyself. For centuries, yoga, pranayama, meditation has been practiced to improve the physical and mental well-being of a person. Colloquially, we have different terms we use. Samastaka mundara chitta. We all have the propensity to have mental health issues. It may or may not be expressed in a lifetime depending on many factors. Suchibai rogo or ritualistic hand washing, obsessive compulsive disorder. Pagala, any odd behavior or psychotic disorder. Chagala, attention deficit hyperactivity disorders. It has been depicted in many movies over decades. Famous character of Nargis in Raat aur Din multiple personality disorders. Rani Mukherjee in Hitchcock, Tourette's syndrome. Tare Zameen Par, Dustin Hoffman in Rain Man, Kajal's character in Tribhanga, victim of sexual abuse. Vidya Balan as Manjulika in Bhul Bhulaiya, with repressed childhood memories. Professor Sanghamitra Das and her colleague in early 2000 presented a paper to elucidate the issues of non-compliance and non-completion of treatment in HIV positive patients in New Delhi. They found that depression is the main cause of non-compliance and not for lack of financial resources in India. The same findings were reproduced in cancer patients. Depression and anxiety disorders often coexist and are quite common globally. It is associated with many of our chronic health conditions. A lot of famous personalities and world leaders like Winston Churchill, Abraham Lincoln, who called it melancholy, artist Van Gogh, Beethoven, have suffered from this and overcame their mental health issues successfully. Thank you. Now I'm going to present two very young, smart physicians. Dr. Smita Das. Dr. Smita Das graduated with MD PhD from Urbana-Champaign, Illinois. After that, she completed her residency in psychiatry at Stanford Medical College, followed by fellowship in addiction medicine from UCSF. She's currently working as the medical director at Lyra Healthcare and a part-time clinical assistant professor with Stanford Healthcare. Dr. Chandan Naik, our second speaker, has been practicing psychiatry for more than 10 years. He is board certified in adult psychiatry. He grew up around Detroit, went to medical school in Detroit, Michigan, followed by a residency in psychiatry in from University of Michigan. His goal is to improve and quality of life and give patients a meaningful life to live. Thank you. Our moderators of this forum are Dr. Smriti Panda. Please send your questions to the chat sessions. We cannot address any individual case or person's questions due to ethical reason. Smita and Chandan, the floor is yours.
Chandan, would you like to go first, or shall I go first?
I can go first because namaskar, everyone. I'm Chandan Naik. Thank you, Nitapa, for the nice introduction. I'm very happy to be here for this forum, and I'm grateful I was invited. Yes, I am a psychiatrist, but more importantly, I'm Ordia. And let me tell you a little bit about our family and my upbringing, because I think that's very important into who I am and why I chose this field. My mom's side is from Cuttack district. So shout out to all the Cutkis out there. Many of my cousins might be watching right now. And then my father's side is from Dhenkanal district. And I have an older sister, Melissa. She's also a doctor. And like many immigrants, we actually traveled a lot growing up. Obviously, I live in the United States now, but we have lived in Odisha, we have lived in Saudi. And, throughout all our travels, we get exposed to a lot of things, good and bad. We've seen crime, drugs, inequity of gender, race, socioeconomic class. But we've also seen some very positive things as well. Love, compassion, tolerance, many systems in place to deal with all the things that we have to deal with. And I think I truly have a good grasp of what is truly universal, good and bad. Psychiatric disorders are universal. They happen in every country, every nation. So I think that was one of the reasons I was interested in all this. I wanted to say also that one of my mentors was an Odia psychiatrist, Dr. Hemant Senapati. He's no longer with us, but he was a great man. He was a great family friend. And him and his family made OSA very fun for me when I was growing up. So what is a psychiatrist? A psychiatrist, like Dr. Das and I, we are medical doctors who specialize in mental health disorders. Mental health disorders include substance use disorders. So that's an important thing to know. My personal view of what my role is, I observe people, I observe patients, and I treat medical conditions. I don't judge, I don't criticize, that's not my role. If I do that, then I'm failing in what I do. My goal is really to approach the situation dispassionately and help the person when they're asking for help. So in the US, my training, is a typical training. I have 4 years college, 4 years medical school, 4 years residency. And I've had many jobs, many terrible jobs, but now I really like my job, and I've always liked my career. I live in Chicago, I'm married. I work in a private practice now. I specialize in neurodevelopmental disorders. That includes things like autism, ADHD, and intellectual disability. The reason I love what I do is not only do I help people, but I learn a lot about myself. Growing up, there's a lot of questions. Am I Ordia? Am I American? Am I an ABCD? Am I a brother, a son, a husband? The truth is, I'm all those things, and we are all those things. We have all these roles, and this profession has given me a lot of peace in who I am and how I fit into my community. So I just wanted to say that as my introduction. That is in a nutshell is what I think you should know about me. And once again, thank you for having me.
Dr. Nayak, thank you so much for that really great introduction. That is a hard act to follow in terms of an introduction. So I'll introduce myself now. So I'm Smita Das. I am a psychiatrist as well. And I'll share a little bit about kind of the path that brought me to psychiatry. And so many of you probably know my mom's on the call, Chinmay Das, but my dad, Gauri Charan Das, who's passed away, he is founder and first president of OSA. And so he is, kind of with that background, he's been a very traditional person. But I love the idea of the women's empowerment seminar because he strongly believed that women could do anything. And so he pushed my sister and I to achieve whatever we wanted to achieve and to believe that we can make it happen. And so sometimes that meant we had to be creative about things to kind of, for me, it meant I had to kind of combine a bunch of different things that fit together to kind of make my dream career. And so I appreciate, his and mom's constant also pushing to make that. And I agree with Dr. Nayak that it's, there's so many different identities we hold, and this profession helps us reconcile all of them. So for me, it was by chance. Going into college, I started a data entry position. I wanted to make some money on the side. I decided to become a research assistant in the Stanford Psychiatry Department. And then from there was the study happened to be on smoking cessation. So going around to all the units of Stanford Hospital, in addition to that, in addition to data entry and working with patients at the bedside to help them quit smoking. So maybe they've been hospitalized for a heart attack or for heart failure, or for something lung related. And I would go to them. It was a 17-year-old who was trained in this and used what was, then very new to me that I had just been taught was cognitive behavioral therapy. So using therapy at the bedside to help people create a plan to quit smoking, and then following up with them by phone once they left the hospital. And what I found is in all of these very complex cases, complex issues, is that behavior change was absolutely important for having them achieve all of their other health goals. And if we didn't approach the behavior change, or if we didn't look at their primary depression or their primary anxiety, we weren't going to get very far. And this applied from everything from heart disease to diabetes. And so after that, really enjoyed public health. So I went for a master's of public health, and then, as Nita said, did my PhD an MD. And I went into medical school thinking I did so much that had to do with the heart, maybe cardiology makes sense. And then that behavior change kept coming back. So sometimes it was behavior change with patients. And then later for my PhD thesis, it was behavior change in hospitals. How can we get hospitals to do the right thing, to implement programs that can help their patients, not just right there in the moment, but for the long term. So it made sense to go into psychiatry, and I was fortunate to match at Stanford again, and then realized again that smoking is the number one, or has been traditionally the leading cause of preventable death in this country. And so addiction is very important. And so did addiction psychiatry training. After that, I had the privilege of working at the Palo Alto VA, where I was director of addiction treatment services. And it was very rewarding to work with veterans and their families. And now I am trying something else. I'm at a startup called Lyra Health, and it offers care to employees, and through employee assistance programs. And then at part-time, I also work at Stanford in an addiction clinic. But ultimately, one of the things that, similar to Dr. Nayak, this profession has allowed me to learn so much and allowed me to grow in many ways. And knowing, for example, how to do cognitive behavioral therapy on patients and kind of going through the practice of learning that in residency, I learned how to do that for myself too. And so things like when our mind can go to kind of the worst possible scenario, when things seem very overwhelming or stressful, kind of breaking it down, seeing what's a logical thought, what's not the logical thought, and being able to find some peace in that has been really helpful for me. And it's been helpful for me in my profession, as a professional, as a daughter, as a wife, as a mom, in all of these ways, it's been really, really helpful. So I just feel fortunate, and also kind of coming back to my dad, the fact that he and my mom supported me in a non-traditional, it's when people think of doctor in India, there's so much stigma about mental health. And so when people think of doctor in India, or if I'm introduced to people, they'll say, oh, you're a psychologist, which is great. I don't mind being referred to as a psychologist, but the truth is I have an MD also, or I have an MD. And so I need to, I would correct people and say, no, psychiatry, mental health as a physician. And so I really appreciate my parents supporting me and taking kind of the path less traveled. I was really surprised to meet Dr. Nayak, because I didn't know that many ODS psychiatrists existed. I know like 2 others. So that's a little bit about my path, and also highlighting a little bit of kind of the stigma and the thoughts around mental health in our culture.
Niti, you need to unmute.
Thank you, Smita and Chandan. As you can see, audience, we have 2 amazing speakers this afternoon, and I know we're all very excited. So the format today is going to be, I'm going to ask some very, very broad questions, and either Smita or Chandan, they can decide who wants to answer it first. And then, or both of them can obviously chime in on the discussions. And while they're asking those questions, if you have any answering those questions. If the audience has any questions related to that particular topic at that time, please feel free to send it in the chat. If you want to remain somewhat anonymous, please feel free to send a chat directly to me, and then I will intermittently ask the questions to our speakers, and obviously they'll do their best to answer them based on the time. Okay, having said that, the first question I'm going to ask is, how common are psychiatric disorders? Smita, you want to take it first?
Sure. So prior to this, we pulled the stats just to have them kind of on hand, and I will also paste somewhere in the middle of this discussion, I'll paste some links that are useful resources for folks. So common psychiatric disorders, and I'll focus in on the US. So 1 in 5 adults in the US has some mental illness. And so mental illness, as we talked about earlier, is very broad, right? It can include depression and anxiety. Those two are the most common ones, but it can also include OCD, PTSD, post-traumatic stress disorder, OCD being obsessive compulsive disorder, and a number of other illnesses, also substance use disorders. So I think depression and anxiety are probably the ones that people can most relate to. So anxiety disorders are the put together, they are the most common form of a mental illness. And so in the past year, and the stats are a little bit, there's different large studies that look at this, but 19% of Americans have had any anxiety disorder. So this could be anything from generalized anxiety disorder, panic disorder, post-traumatic stress disorder in the past year. And there's a 30% lifetime prevalence. So over lifetimes, there's a 30% chance of having anxiety disorder. With depression, 7% of Americans have major depressive disorder. It's higher for women. It's 8.7% of women. And then I think it's also useful as we're talking, with a lot of parents here, and not just parents, but also grandparents, to think about young people. So 13% of adolescents and people 18 to 25-year-old have depression. That's more than 1 in 10 young people have major depression. And kind of what's more disheartening is how few people get treatment. So 35% of adults with major depression didn't get any treatment. And it's even worse for kids. 60% of kids with major depression, kids and adolescents, don't get any treatment. So there's the numbers of how common these things are, but then there's even a bigger gap of people not getting treatment. And then the last stat I think that's useful is about suicide. And this is a difficult topic, but obviously a very important topic here is that suicide is the second leading cause of death among people between the age of 10 to 34. So that is a very, very high number. And so, I think sometimes when I'm so glad that we're having this discussion because we're talking about these things, we're bringing them to the forefront. And I think Dr. Nayak and I, if anything, if there's any take home from this, it doesn't have to do with statistics or treatments or whatever. It's just to start the conversation and to be open to this and to talk about it and to be aware of it in our family members and our loved ones.
Yeah. I couldn't agree more. I think the best way to combat stigma is to talk about these things. We all have to talk about it as a community. We should not view it as necessarily a negative thing. To a certain extent, it's human nature to see these things and we see it as either weakness or something negative, but really it isn't. We have to embrace all the things good and bad that happen in our community. The World Health Organization lists mental health disorders in the top 3 most disabling conditions in the world. It happens everywhere. You said 1 in 5. I think it's also 1 in 5 in India, where people have mental health disorders. It's similar rates, which is very interesting to me. There's, $300 billion a year in healthcare costs just for substance use alone in the United States. So that tells you a lot of what the impact is. So we have to take these, we're citing a lot of numbers here, but we have to take these things seriously. And you know, things like suicide, it's uncomfortable to talk about, but when it happens, is devastating. You know, it's happened in our community, and it's happened in my family. You know, I don't want to make light of the situation, but you know, things have happened in my father's side of the family, and I ask him before, and he'll be like, "Oh, well, that was a long time ago that happened," and I'm like, "Well, what does that mean, Dad? We have to talk about this. You know, we can't just sweep it under the rug."
Okay, Smita and Chandan, I have some questions coming in on the chat. This one is going to be to Smita first. I know you were giving out some statistics about age and male, female, about psychiatric disorders. One of the questions is, can you say anything specific as it relates to Indian Americans? Do you have any kind of statistical breakdown for that, or do you know if any major studies are being done with that category or that group?
Yeah, I do have some of that. And then I also, Dr. Nayak, you had shared a really great, Lancet article. So I might flash one of those images. I think the map image is really interesting.
Yes.
But with South Asian Americans, there's, and I can share these studies, as I said, in the chat later, so folks can look them up as well. So we know that there's a lot of different things that can contribute to mental illness or to worsening outcomes in mental illness. And so one of them, for example, is the fact that a lot of South Asians are still kind of in that immigrant status. So having come here, maybe their first, second generation. So that is inherently a stressful thing, right? And then the intergenerational conflict. Dr. Nayak said something like, am I an ABCD? That's also something that can come up. You know, what are our identities and how do we reconcile those things? In terms of the diagnoses, I'm not going to give numbers here, but I'll say kind of some trends. So interestingly, women, I'll focus in on this because this is a women's empowerment seminar. Usually, so in the US, for example, or in Western societies, traditionally, suicide rates are higher with men. But interestingly, with women, suicide rates are higher with South Asian immigrant women than among South Asian immigrant men. So there's already a place where there's a disparity or there's a difference that where women are being more affected. Indian women are also more likely to report that treatment for depression is not beneficial, and did not believe that a visit to a general physician for a referral to mental health services is necessary. So this idea of like, I don't need help. This is something that I can control. It's going to look bad if I go and I seek help or I talk about this. It's going to be weak if I do this, and I have so many other things I need to manage. Those sorts of ideas come into play in the literature when they research why is it that South Asian women don't seek treatment, and even though they're suffering more. And then interestingly, I think the other thing that this article has this article is a review, so it takes all of the literature and kind of tries to digest it, is that older adults, especially older South Asian women, end up feeling more of the psychosocial stress in the community. And that also leads to depression. So, there's the rates of psychiatric disorders in South Asian people specifically haven't been studied as well nationally. But we do see in Asian communities in general, that there's a lot less usage of mental health services, even though we know that they may have a mental health concern.
Okay, I'm seeing a lot of questions come in the chat that are kind of specific relating to communicating with children and other things. We can either discuss that now or we can go on and then come back to those questions towards the end. I'm going to leave it up to the two speakers to make that decision since we have other questions. If not, I'll go ahead and make a decision. Why don't we go ahead and move forward with the other questions, and then we will go ahead and bring up all these questions towards the end. So this way, it'll open it up for time, open forum discussion. Some great questions are coming up that I think are very, very relevant to our community. So having said that, I'm going to move on to the next question, and that is, what makes something a psychiatric disorder? Any specific definitions, or, as doctors, how do you define it? What makes it? And I know I've had some that if you could, they would actually like some definitions, if you can post that later on.
Sure, I can answer that,
Okay,
Dr. Dasa. If we go with, let's say, depressive disorders, I'll give you a nutshell because I don't want to go into all the specific DSM criteria, but, to me, it's not just normal grief. We all have gone through pain, sadness. Pain is, there's a quote by this poet, Khalil Gibran. It's pain is the breaking of the shell of your understanding. So it is natural to have pain. In Buddhism, they say samsara, that is a natural part of life. Yes, you have a breakup, you have a death in the family, a move, any big life change, a loss. This all can cause pain and suffering, but usually that will go away and you adjust and adapt. When it persists and it starts interfering with your life, that's when we consider it a disorder. So you look at the DSM criteria, it applies to Americans, applies to Indians. Depressive disorders in general, you need a depressed mood most hours of the day, most days of the week. An anhedonia, which is inability to have pleasure. So you're not enjoying things like you used to. Typically, this goes on for a long time. In a classic major depressive disorder, it's 2 weeks. So anyone who comes in my office, I ask them these questions. But the main thing I look for is, how much is it interfering with your life? Having sadness after a loss is very normal. It's your body healing itself. But if you have things that are probably more subtle to other people, but are more obvious to me, poor work performance, these symptoms are invading your work, poor communication at home, especially men, you're withdrawing from family, withdrawing from your household. Students, poor school performance, once these things interfere with your personal or occupational or social life, then that's the definition of a disorder. And what that really means is it's a good idea to seek treatment, and you should seek treatment from a professional. I want to add too that, we have a tendency, regardless of culture, we have a tendency to minimize these symptoms. So, my mom's favorite word at one time was oraswa, calling someone lazy, not that she ever minimized psychiatric disorders, but, that's usually, a first assumption. Another is, we assume that some people are just, being pulays, they want attention or they're just going through the motions. We assume it's a weakness and we assume it's a choice, but I encourage everyone not to assume those things as the first go-to. Really look out for how much interference these symptoms have with your day-to-day life.
I'll just echo what Dr. Nayak said is all of the DSM criteria. So the DSM is the diagnostic statistical manual created by the American Psychiatric Association. And it's evolved, and I'm not going to pretend that psychiatry has been perfect. I think we're working on trying to improve things, and also to make psychiatry more inclusive. So this is the manual that we use to diagnose people, and usually there's X number of criteria, usually anywhere from 10 to 16, depending on the disorder. And if somebody meets 2 or 3 of them, then they have a mild disorder. And then if they meet 4 to 6, I'm just kind of giving ranges here, they may have a moderate. But the bottom line is all of those criteria, aside from some of the symptoms, they have to do with the impact on functioning. So it's whether it's depression or substance use, somebody can, for example, drink alcohol, but it doesn't impact their functioning. And so it's, you know, it's useful to have that impact on functioning and their life. And functioning doesn't just have to mean work and school, it's relationships, it's taking time away from the things that you normally do. It's basically something that is hijacking your life. And I really love what Dr. Naik said about the concept of the judgment, right? And that these disorders, we can't say, oh, that person's choosing to be depressed, or that person's choosing to be like this, because these are actual issues related to the brain. I'm sorry, there's a buzzing.
I hear that.
You hear it? Okay. Someone's unmuted.
Smita, is there another device that's on that you're getting an echo effect?
No. If I mute myself, does it go away?
Can you mute? Can you please participant to begin your mute.
Yes. Okay. Let's try it now.
The concept of this is a choice. And I really love to use like the metaphor with any other main physical illness. So diabetes, for example, if somebody has diabetes, and we use all sorts of like measures, we can get, you know, what's your fasting blood glucose, we can look at what your hemoglobin A1C, which shows us a longer amount of how long sugars are glycosylating your cells. So we say, okay, over the last 3 months, your diabetes is this bad. And we get these numbers and the doctor says, you need to take metformin, or you need to do, you know, we might have to start talking about insulin. You need to check your blood sugars on the daily. We don't judge that. We, you know, and we wouldn't hesitate if somebody said you have high cholesterol, you're higher risk for a heart attack. Let's put you on Lipitor and, you know, take this seriously. All of us, for ourselves and our family members, we would jump to making sure that our loved ones and ourselves get that care. And yet, with depression, with any other mental illness, it's generally treated like a choice. And this isn't just in South Asian communities. It is in a lot of communities. And we don't recognize that this organ, the organ we have here, our brain, which is so important for everything from, you know, getting a good SAT score or an MCAT score to when somebody cuts us off on the street, how we react. Or do we get angry? Do we kind of shut down and cry? How do we react to that? This organ is so important. And yet when this organ is suffering from a true brain disease, we treat it as a choice. You know, one could argue, a psychiatrist could argue that, you know, some parts of type 2 diabetes are a choice, you know, diet, exercise, all of, you know, this ghee that we eat, like those are all choices we make. And so why do we treat depression as something that's a choice and somebody's fault when we have ways to treat it and we know it is a brain disease?
Thank you both talking about the depression, the illness. I know there's gonna be a lot of questions about that. And I really appreciate the fact that both of you really related that to our day-to-day lives where we are overwhelmed or we do go into depression, just a feeling of sadness, you know, caused by changes in life. So I know we'll definitely be coming back to that with a lot more discussion, very, very relevant topic there. The next question I have for both of you is, what are some evidence-based options? Smita, do you want to take it, or Chandan?
I can start and then Dr. Naik can join. I'm glad that you brought up evidence-based options because we do have a lot of treatments that work. So kind of my soapbox that I'm on anywhere I speak about mental health is that we have treatments that work. They're just highly underutilized. So for example, for depression, we have guidelines about how best to approach depression. So if somebody has mild to moderate depression, or they've just had a first depressive episode, then it may make sense to start with therapy. And there's lots of types of therapies out there, and many of them are very helpful. There's some that have kind of more evidence than others, but I think I would argue for whichever therapy somebody's going to engage in and feel comfortable in, and if they have a good therapeutic alliance or relationship with their therapist, that is one of the most important things. But to give some examples of what an evidence-based therapy is, for example, cognitive behavioral therapy. And I think cognitive behavioral therapy is actually really great for like this South Asian community, because it's very logical. It's very logical. It's got structure to it. If somebody is coming from like a lot of people here are from STEM backgrounds, like it makes sense. And so it's a way to feel better and feel better quickly, to develop coping skills. So that's therapy. And then for people who have more severe symptoms, it makes sense to combine therapy with medications. So for medications may be antidepressants. For somebody who has anxiety or depression, antidepressants are the main way to treat those things. And then, for other disorders, you combine other medications as well. So we know that in kind of every study that's done on almost every disorder in psychiatry, a combination of therapy plus medications improves outcomes for the long term.
Yes, and echoing what Dr. Das said, I want to say that in my office, what I try to do is have a very personalized approach. When you meet a person for the first time, you really don't know what's going on. You ask more questions, and my analogy is, I get a few dots on a paper, and I'm trying to draw a picture, and the more dots I have, the more complete picture I'll have. So if somebody comes in with a major depressive disorder, yes, I can go through the algorithm, sometimes therapy, sometimes medications. But ultimately, I want to do what works, what that person is most comfortable doing. Some people come in my office, they say they absolutely don't want meds, and I have to respect that. There's very few conditions where we have to do medications, but correct me if I'm wrong, Dr. Das, but depressive disorders and anxiety disorders, we don't have to do medications all the time.
Okay. I'm going to start asking some questions here. One that just came in, and I think is very, very relevant, because I see a lot of parents on here, and this would be beneficial to them as well as the college-age kids or high school kids they may have. One of question is, as a college student, what precautions can I take to make sure that I am keeping my mental health as a priority, especially during the pandemic?
That's a tough question, but I think staying connected to people you trust, staying connected with family. The big challenge right now is social functioning, social isolation. That can go many different directions, but I encourage. Did you say college students?
The college age, but
Yeah.
even though this is asking about college age, I'm sure this can also be broadened to include high school students, any student, as well as their parents. I think everyone kind of is dealing with the issues as a result of the pandemic and dealing with mental health.
Yeah. So this is a kind of a tangent, but I think, with students, younger Ordias and immigrants in general, a big struggle we all have is identity. And when we go to college, we're desperate for a connection, for a bond with others. And sometimes that can lead to hanging out with questionable people, which I mostly did in my 20s. It can lead to behaviors like substance use that are not necessarily healthy. Some people right now, because of the pandemic, are having a lot more substance use. Some people are having less. It's very interesting how everyone reacts. Everyone is reacting very differently. So, I mean, above all, I think you have to keep a connection with people you trust and healthy people who like family and family friends who are out for your own safety for the long haul.
Okay. Smita, would you like to add anything to that?
I was just going to say also self-awareness. So the fact that the questions even being raised is really great. The fact that everybody is here is really fantastic. So, looking within kind of doing checks, just like we would do, as I said, a blood sugar check, like checking with yourself, how you're doing, and then knowing and being, making that step. The thing, so people will ask me, with psychiatry, don't you feel sad, doing this day in and out, you get to hear about everybody's problems and life is rough. And I actually say that when somebody steps into my office, or as the case may be now, gets into my Zoom room or my video room, they're taking such a huge step. So having the bravery to take that step, to just talk about it with someone, if it's a professional or somebody else. And it may not mean that you end up needing treatment or needing to go down that route, but having the bravery to talk about it. So checking yourself and then having kind of the bravery to talk about it with someone else is really important. So the piece of connection that Dr. Naik was talking about is very important.
Okay, the next question I'm actually taking a couple of questions and kind of consolidating it. So audience out there, if you don't feel like your question was answered directly, it's because I've read the chat and I felt it'd be more beneficial to consolidate and ask just a general question. We've talked about a question from a college student. Now there's some questions from parents. How do they go about talking to their children about mental health, and what can they do? As parents also struggle with the pandemic, and how to make it easier for their kids. So it's a loaded question. So maybe we can talk about, I know as a parent myself, it's a challenge as how do you talk to your kids? And so it's, there's some struggles as a parent, not just talk about mental health, but talk about peer pressure and all of that and for me, it was a little bit easier. I grew up here, so I could identify with what my kids were going through as we started talking about some of these issues. But my husband was going to have a little bit more difficult time because he's first generation OSA. So having said that, I know there are a lot of parents out there who may see changes in their kids, may see that there's something that's not quite right, but how do you put the pulse on it and how do you start that conversation?
So everything that you just said totally resonates. I am so thankful for all of the work and sacrifices my parents made to bring me up. And I know that it was a challenge, for first generation. It is a challenge because you're trying to figure out this country. You're trying to kind of make it. Bappa will talk about how when he left home, just the small amount of money he had in the one suitcase, and how, I feel so thankful now that we made it. And so just that struggle is true for many first generation parents. I think I have a leg up as a second generation American, South Asian American parent, in that, and also having been through psychiatry residency and learning about development, kind of regardless of whatever all the theories are, and there are some aspects of Western development theory and Eastern that clash, and that's something that's frustrating for me as a psychiatrist. But kind of the most important thing is dialogue, and just opening up that dialogue and making that dialogue a non-threatening entity. So we're not, when we're talking to our kids, they feel like we just want to learn about them and we want to be a partner with them, instead of we are here to discipline them or to always give them advice. I think it's so easy as an older person to just want to give advice and feel kind of a little hypocritical because I'm sitting here kind of in some ways giving some advice or insight, but that we don't always have the advice, that sometimes we just need to listen and hold that. And so if parents with children, either young or if they're very young, starting that early and just making that part of your culture, part of your routine. So sitting down at the dinner table, you don't say, "How did your test go today?" Or did you get an A on that test, or did you finish that homework? These are important things, but checking in about the process, checking in about how they're feeling is a part of the essential conversation that I think oftentimes for families who are just struggling to like make it and to figure it out, like those kind of are harder to include, because it does matter how that test is. It does matter how somebody did, but a loved one gave me a book called How to Raise an Intelligent Child, and when I was pregnant. And I said, thank you. And I read it. And my response back was probably not very respectful, but I said, I want to try to raise, and I'm still working on this, I want to try to raise a happy child, because it doesn't matter how smart a kid is. If they're unhappy, it's really heartbreaking.
Chandan, do you want to add anything to that?
Sure. I'll be brief because, I don't have children, so I don't pretend to know what goes on with parents. But a couple of things, I think I encourage parents to somehow, make it very clear that your children know that it's okay to have these issues. When I think of this, many different thoughts come up. One is my mother-in-law always says, she's a counselor and teacher. She always says, I try to remember how I was at that age and try to empathize as much as possible. And then the other thing is just, fundamental differences between Eastern and Western culture. In general, Eastern cultures are more authoritarian in the household in terms of roles of parents, and there's a more suppression of emotion. Whereas Western culture is, it's more like a democratic orientation. Children want to make their own decisions or own freedom. And also, sorry, I lost my train of thought here. Also, they want to express their emotions. They want a safe place to express those emotions. I think a timing is a lot of it too. You can't ambush a child. You want to make sure they're in a good mood, you're in a good mood, and try to have a calm discussion that goes further.
Okay, I'm going to switch gears a little bit with the questioning. Had some questions about Alzheimer's and genetics. So can both of you, either of you, speak to how much of mental illness would you say, and again, I'm consolidating the questions, would you say is genetic, and how much of it would you say is probably environmental?
So studies will generally kind of, it depends on the specific disorder, but usually it ranges anywhere from 30 to 60 or so percent. And Dr. Nayak, correct me if I'm getting numbers off, but usually somewhere between 30 to 60%. And then of course there's other components, right? So somebody, for example, this is a very concrete example, somebody who has alcohol use disorder in their family, if that person never touches alcohol or has a drink, then obviously they're not going to develop alcohol use disorder. And then it's not just that they environmentally use the alcohol, it's also that they, at what point in their brain development do they use it? The earlier that we use a substance, the more likely there is a risk of developing a disorder, especially if you have a genetic load for that. And with alcohol, it is 50 to 60% is genetic load. And then on top of that, how much do you seek treatment? So I think this is actually a really important point, is that with any psychiatric illness, the longer we let it go untreated, just like the longer we let our diabetes go untreated, the longer we let our heart disease go untreated, the longer we say it's a choice, it's a moral thing, the worse we are off. So, it's never too late to get treatment, and the earlier we do it. So there's I use what's called a biopsychosocial formulation, where we take the biologics, so the perpetuating, the precipitating, the protective factors of the biology, that includes the genetics, the psycho, which is how, you know, somebody is are they psychologically minded? Do they look into themselves for things? And the social, what is their environment like? Somebody who's in a very stressful environment is going to have less ability to cope with these things. So it's a combination of all of them. But there certainly is an element of genetics. And again, that comes back to the interplay of the brain things. Does that mean that somebody who has this in their family means that they're going to get this? No, that's not at all what it means. But it is something that if we know that a family member has X, Y, and Z, then we can be proactive to try to, just like we would do with heart disease. If I know my parents have high cholesterol, then I know that I need to, you know, do the things with diet and exercise to try to combat that. And it's the same thing with mental health.
Okay, thank you. I've had some messages about whether this is being recorded. Yes, this seminar is being recorded. So if you have family members or friends that are not able to join, this will be available to them. And I know we'll send out the information about that. So
I don't see the record button, Smriti Nani. I asked Utkal in the beginning. It's there on the YouTube, but it's
YouTube.
Not, but not on recorded. Yeah.
YouTube,
so it's on YouTube. We'll send the link out.
Yeah.
Yeah. So
and I'm also seeing some questions that are very, very specific. And I haven't read those because, again, I think we made it kind of established early on that Smita and Chandan would not be giving any true individual diagnostic advice. This seminar is going to be general. So if I haven't read yours, it's because it may be something that is a little too specific. Just to keep things a little lighter, can you talk about any alternative ways of dealing with anxiety or depression or just feeling of heaviness? How can yoga or other things play into this?
I guess I can start with that question. I mean, I'm interested in yoga. I see it, you know, yoga, Buddhism, and also this type of therapy called DBT. I see it all kind of interconnected. If we look at, you know, a term like mindfulness, so it's being aware of our body, aware of our emotions at the time, and you know, I see nothing wrong with like a morning yoga meditation practice. Why not start the day off right, start it calm, because you know the entropy or chaos of the day, you know, after the morning, you know, you can't control really what the day brings. So I think yoga is a great way, great way to relax and deal with the anxiety. Yoga is actually recommended for, in some situations. I'm forgetting specifically what it is, but I know that when you're pregnant and you're having anxiety, yoga is recommended. I believe massage is also recommended. So it really is a kind of a time and place situation, but there are many alternative treatments.
Okay.
Tai Chi or Taekwondo or whichever, all of those Eastern exercises, they do help release neurotransmitters. Oh
yeah, and let me just say, yeah, I forgot exercise. So you know, a lot of the advice that psychiatrists give, it's the timing is different from primary care. I mean, eating right, exercising is ultimately more important. But so you know, we kind of do things in a different order. If somebody comes in, they're having an anxiety disorder or depressive disorder, yes, we treat sometimes with therapy, sometimes with medications. But ultimately, and you want to reflect back on what was the situation that caused this, what things can you do, because your situation after treatment, you have to change it on your own. So exercise does help. When you start feeling better, I think that's a great time to do exercise, and you'll have the naturally more motivation, more time to do it.
Okay, here's another question I think is really relevant. When there is first indication of mental health issues, how do you go about finding the right professionals without knowing whether it's clinical or non-clinical? And I know this was addressed a little bit before, but if you could just give some more additional information about that.
So I think a really great place to start is your primary care physician. They can usually point you in the right direction. What's great is we realize there's, for example, not enough psychiatrists in this country. And so primary care has really done an amazing job of trying to integrate some of this screening into their practices. So when you go to see your primary care doctor, you'll do these surveys and you'll think, oh, there's no reason, why am I doing this survey on, asking me about my mental health? But it's great because it catches a lot of people and helps route them in the right direction. So just starting with a primary care physician, I would add, I think sometimes primary care physicians have so much they have to clump into a 20-minute visit. So if you can make an appointment just to talk about this or send them a message just to talk about this is really helpful. And then seeing kind of if the primary care physician has some recommendations, and then the other places, a lot of, because with the passage of the Affordable Care Act, there's more parity or more equality between, other diagnoses and mental health now. So insurances oftentimes are able to try to provide you with a list of people. And if you really felt like, okay, I do need to see somebody, and you don't want to go to the primary care doctor, you can get a list from insurance and contact people that are within your network.
Okay, here's another question, and you've actually answered part of it, which is, how to go about contacting your primary physician to get help and how to. There's some questions here about OCD, and how do you recognize it? And I guess to general, and what is the difference between I'm washing my hand because that's what I do and that's what I was taught to do versus when it really is OCD? If you could just give some general examples about what it constitutes OCD and what can someone do to get help for it?
Sure. I can touch on that.
And anxiety, because OCD obviously and anxiety seem to go hand in hand.
Yes, they do. Yeah. It's kind of an academic discussion, is OCD its own disorder or not? But it's obsessions, compulsions, and typical obsession would be like thinking about germs, worried about germs, which is very commonplace now during this pandemic. Compulsion would be hand washing because you're fear of these germs. But there's something I usually ask for. The term is magical thinking, but it's one thing to wash your hands. Honestly, I wash my hands probably like 30 times a day, but how much is it interfering with my life? This goes back to what Dr. Das and I said earlier, does it interfere with your social functioning? Does it interfere with work? And then also, like, how superstitious are you about it? So magical thinking is, you think, okay, if I don't wash my hands, then I'll get a virus and then I'll accidentally, and then it gets pretty dark. You start thinking, an accident will happen or you will kill somebody in your family. It gets a little extreme. That's driving some of the obsessions and compulsions. So, and I can go on and on, but OCD is in my opinion, a lot more genetic than most disorders. It's in the spectrum of disorders, like it's highly genetic. So I want people to know, whoever's experiencing that OCD or Suchibai, that you're probably not in control of all these things happening. So the medications typically are serotonin medications, what most people would call antidepressants. And I'm sorry, I'm getting ahead of myself. The mainstay treatment is cognitive behavioral therapy. And then in addition to that, medications are usually the serotonin medications like Lexapro. There's another one, clomipramine. There's a whole list of medications there.
Thank you. Smita, do you have anything to add to that?
I could touch on the anxiety part of it. So I love Dr. Nayek's description of OCD. I think, starting with the therapy is helpful, and even exposure as well, to help somebody kind of slowly know that it's okay if you don't wash your hands 50 times. It's hard right now with the pandemic because we have to wash our hands. We have to be mindful of those things. And so a lot of patients are presenting with, I don't know if this is like pathologic, or if this is like considered an illness, or if this is how I should be doing it. And what Dr. Nayek said about the distress is how much distress is it causing you, and how much is it interfering with the rest of your life functioning is important. And the other thing I'll say about anxiety is that it's the exact same thing. It's how much is it? We all worry, right? If we're in our job, or if we're in school and we have no worry in the world, we just say whatever and don't meet a deadline and don't do our assignments, that's reckless. But then if all we do is we worry about those things, and there's definitely been, my mom's smiling probably because she knows that this is partially describing me, but if all we do is we worry about like this paper and that paper, and we need to get this deadline done and that deadline done, and it interferes with our ability to function, then that's a problem. And so when those things have interfered for me in my life, and I'll give a very concrete example. I was taking the Caltrain, this is kind of on the border of OCD and anxiety, but I was taking the Caltrain actually to the American Psychiatric Association meeting in San Francisco. And I parked my car in Mountain View and near the train station. And then I got on the Caltrain, and somewhere between Mountain View and San Francisco, probably in San Bruno, I started to worry about whether or not I parked my car. And now this is my really not great car from medical school and had nothing valuable in it. But I started to worry about, where did I park my car, and did I lock my car? And I couldn't shake that feeling of, did I lock my car? Did I lock my car? And I had to go and I had to present at the APA, but I got off in San Bruno. I took the Caltrain back to Mountain View and I checked the car door. And in fact, it was locked. And that sort of thing, that worry, it was destructive. Now, if I had worked through that in cognitive behavioral therapy, I would have said, okay, what's the worst that'll happen if I didn't lock my car? Well, in the worst case scenario, somebody opens it and they take the candy that I have in my glove box. And that's not really a big deal. Or they open my car, they somehow figure out how to turn it on, and they drive away with it. Okay, is that the end of the world? Is that something that I'm not going to be able to deal with? It would be stressful, but I would still be here, and I would be short a very not so good car. And so it's the impact that had on my functioning, and the fact that I couldn't shake it. And that was just one example where in that time in my life, this was happening a lot, and that functioning was it's not just one incident, it's kind of multiple incidents put together that impact somebody's functioning.
Okay, thank you both. Here's another question, and this is a little bit different. It's on the issue of medication. And the question is, if someone needs to get on medication, isn't the goal to get the person off of it after a certain amount of time? Or if you need medication, are you required to take it for a lifetime because you are neurologically wired with a deficiency of some sort?
That is an excellent question. There's no clean answer to that. I can tell you that I'll just give an example of like major depressive disorder. The initial recommendation, if the doctor and patient agree on medications, the way we're trained, you do a low dose, start low, go slow. It takes a month to work. It takes a few weeks for this particular medicine to work, antidepressants. And when you start to feel better, then the discussion changes. Are you meeting your goals? Are not just symptoms, but are you moving forward in your life, whether it's work or home or whatnot. For the American Psychiatric Association for classic major depressive episodes still says, if someone is stable, like for 9 months, I'm not exactly sure why it's 9 months, but then the discussion changes to, do you still need the medicine? So you weigh the benefits and risks of the medicine, the pros and cons, Is the medicine helping? Yes. Is it causing side effects? These medicines sometimes cause stomach side effects, sometimes cause sexual side effects, which we don't talk about in our community as much, but in a psychiatrist's office, this is part of our job. So it becomes a trade-off. And then the recommendation is, if you're stable, to try to do as little meds as possible. But I also want to say that if you think about it, some of that doesn't make sense, because let's say you had a loss in your family, then you become depressed. Yes, there was some dip in serotonin in your brain, and then we are artificially giving you more serotonin. Then why would you not need it in 9 months? So there's a lot of questions there, more questions than answers. But the assumption is that the medicine or whatever, even therapy, stabilizes those neurotransmitters, and it's almost like resetting your computer. Your brain starts functioning more independently like it used to be.
I'll also add that medications are just a tool, just like all of these other things. So at that 9 months that Dr. Nayak mentioned, I think the recommendations also include like trying to make sure that in that process you're engaging in therapy, that you're building up coping skills so that you can effectively get off of that medication. For people who have multiple, and this is kind of, we're talking more about depression and anxiety here, but so if people have multiple depressive episodes, then sometimes it makes sense to be on medications for longer, but always my goal is to try to simplify, a medication list as much as we can. And then Dr. Nayak mentioned that there's some disorders for which kind of we have to consider medication, and those might be in the longer term. So for example, in bipolar depression, where somebody has repeated manic episodes, like true manic episodes where they're not sleeping for multiple days, they're doing things that are outside of what they would normally do, or things like schizophrenia, those medications may need to be on longer compared to like an antidepressant for a major depressive episode.
Thank you. Here's another question. There's a question about support groups for parents, and lack of support groups for parents of children with mental health or special needs is a major problem. And then I know sometimes as a community, we don't really talk about children with special needs. Do you know of any support groups that exist for these parents for the Southeast Asian community? And if you do, if you could talk about that and maybe post the links or any information you have in the chat.
In the chat, I know of several. I work with people with intellectual disabilities, so it'll be really specific to location, but I'm actually looking at it right now. But there's it depends on the condition, but there's DBSA support groups, there's NAMI support groups. Generally, the bigger cities have more resources, but I'll be happy to send the links. Sorry, I'm not great with the Zoom technology right now, but I have a ton of links I'm happy to send.
You guys are doing a phenomenal job. I mean, just the questions that are coming in, it's amazing. Here's a question. Okay, kids born and brought up here should see someone who understands Indian parenting culture, or one who doesn't have any understanding of Indian parenting, or is that not relevant at all? And I reading this out because I think this does play a lot into the comfort of families who are willing to go get counseling or see a psychologist. And I know cultural issues do come into that conversation. So if both of you could speak to this a little bit.
So I've struggled with Western psychiatry in this way, and I alluded to this earlier. When, for example, I'm seeing in residency, I was seeing some patients who were of ethnic backgrounds, either Indian or Asian or Latino. And when I would talk about them it was a type of therapy I was learning called psychodynamic psychotherapy, and we talk about the developmental changes and the stages that somebody goes through. We can't pathologize that some people have, in some cultures, that the connection between the child and the parent is might be more long-term, or that there's households where you have more than one generation, right? Like an intergenerational household. And unfortunately, some of the theory in Western psychiatry doesn't always account for this. And so, when what a child who's South Asian might look abnormal to somebody who doesn't have that context, for them in the context of their culture, it is very normal. The DSM is really, the psychiatry in the West is trying to integrate this more. So in the DSM-5, which was the 5th edition of the manual that we use for diagnosing, they have a section in the back called the culturally competent psychiatry. And actually one of our local psychiatrists, Francis Liu, he helped lead that, and he's of Asian background, obviously, and his thought was to try to integrate some of this into how we think about culture. And I think my hope is that in the future, these cultural aspects, because if America is a melting pot, then we have more people who need that cultural aspect of psychiatry. I hope that's integrated more into how we practice, how we are culturally competent. So for me, when I recommend, if somebody is struggling, for example, with family issues that have to do also with that family dynamic that is different from what might be considered traditionally Western, I do think it is useful to see someone who has some awareness of what those structures might be. They don't have to be of the same background, but at least having some awareness and some appreciation for those aspects of care.
Thank you. Here's something different. I think this is really relevant, as many of us are, like myself, we call the standard generation. I have, my father is 86 years old, and I've got 2 young adult children. So everyone needs as I laughingly say, everyone needs a little piece of me. So having said that, could you speak or discuss about the mental health of caregivers? And, as sometimes as the standard generation, we are caregivers for our elderly parents, and we never stop being caregivers to our children, be it toddlers or young adults.
I can tell you that, I work basically Tuesdays and Wednesdays in nonprofit settings with families who have children with intellectual disabilities. And it's all the history I get are from caregivers. So I'm completely reliant on caregivers, and they're all women. It's 100% women. So I know there's men out there too who are the caregivers, but they play a tremendous role in our community. They keep everything together, I think their needs are very important. They're probably, the way gender roles are in older times and also, relevant now. Women kind of do everything in the household. So it falls on their shoulders. So I think it's very important that they reach out for their own needs. It's easy for people like my mom to take care of everybody else, but it's harder for them to take care of themselves. So I think it's very important, their needs. And I don't know much else to say about that, but I welcome them to come see a therapist and see a mental health professional.
Is there things that caregivers can do to
take
care of themselves outside of to see a professional? I think caregivers, by the time, and I could be very wrong with this, but my observation has been, by the time a caregiver realizes they need caring for, they're usually falling sick from taking care of everyone. So how do we encourage caregivers to get mental health support?
So Smriti, I can talk about this because I deal with this every day. What I tell people, suppose a patient has dementia, for example, even in the early stages, I tell usually the caregiver that they can join the support group like they have for American Cancer Society if they're taking care of cancer patients for dementia, and we have local numbers. Lot of the local big hospitals also have support groups on some days. Sometimes some churches have. Depending on, sometimes they have support groups in some temples, depending on their religious beliefs. That's the first place. Secondly, I tell them that every day they at least have to take 2 hours out for themselves. Believe me, most of them don't even get 5-10 minutes. So they have to take out, they should not feel guilty because they feel guilty that though they're neglecting, the patient fell because they left them or whatever. That they may have to find someone or pay someone or help a friend. The friend can babysit or be with their loved ones for 2 hours and they can do it if they can help them when they need it in different ways. It doesn't have to be a caregiver, it can be for different things. A lot of churches have also healing services. So those people, because some of my patients told me, so it's not just for healing, it's also they help people. They provide the services like transportation or food, things like that. So at least they should try to exercise. I'm not talking about a particular exercise, but anything, but 2 hours they have to take care of themselves. They can go out, they can take a nap, they can read a book, do whatever, but they have to take some time every day for themselves.
Thank you, Nitapa. In the interest of time, it's almost 3:30, so I'm going to start wrapping it up. But before I do, there is this one question out there, and this I don't think really has to be specifically just for our amazing speakers, but this is really, I think, to the community. And if people want to jump in and say some stuff about it, feel free, and then we will wrap it up after that. And the question is, should we start a support group in our community for mental health? And of course, the other part of it is, would one of the health professionals, mental health professionals, be willing to moderate? Now, that's a large order for both of you. But aside from that, I'm going to put it out there as a community, as a group. Do you think it's time that we started a support group to discuss mental health, to come together to help each other? It's open forum right now.
Smriti, this is Chandra Mishra. Can you hear me?
Yes, I can.
Yeah, I am a registered nurse and I was also a research scientist. I did in public health. Why I'm telling, I have seen it as a nurse. I worked in the mental health. It's needed and we must do that. I have loved ones, wives have died because they mentioned it very later. So also the children have done suicide, colleges. So we need it. We cannot do that keep it inside. And what you said about caregiver, I echoed with the same thing. Even if you pay, still you bring those 2 hours, even if the person can go out and read a book or sit under the tree, it's like it's needed. Well, you must take at least 1 or 2 hours, even if you pay. Sometimes, we think, oh, she's coming and sitting down, but that's important. And I would advocate that we must have because we have that stigma, kahaku kahibani, we should not talk to other people or to our children. I felt very guilty when the college student, did suicide. I wished I knew we could have helped. So I don't know. And I'm a healthcare professional. I'm retired, so I can help if somebody is making. I can help in the sense I can help as assisting whatever is needed. That's what I'm saying. I have seen it in my hand and in my eyes, and I feel bad that we didn't have that, and stigma is that. And they're my age, they're gone.
Thank you so much. No, definitely. Again, I think it's going to depend on OSA and how we move forward with
So
this.
I have a question. So we have a wonderful like OSA Health and Wealth, right? So can they help like if I like
I mean, to put together a group.
like something like instead of like I can like reach out to anyone for like.
Okay, so I
When
can
we have that group is so good, so wonderful.
I think also leadership may need to kind of look into this, and maybe the women's empowerment group can look into creating a.
Smriti, I'm part of OSA Health and Wellness, so I can talk. We have discussed about this. Anjiappa is also here, and Rajshripa, we have talked about this.
Hello, this is Tita Das. I would jump into it. We need support. We need to address this issue, may it be formal or informal.
Yes.
We certainly need support to each other. This has been already there for many, many years. Now it's time, since everybody is eager and conscious. I think that is a perfect indication. Thank you.
Okay, I'm going to introduce this is Swapna Swapna Das that has her hands raised. Could we give her a chance to speak?
Yes, actually, I'm a clinical psychologist, and I was very keen on listening to this. And thank you so much, all this, both the speakers. It was really great. And yes, if we can provide a support group, I can be a part of it also. So in future, if we decide to.
Okay, so what I'm hearing is there's a lot of interest in starting a support group. So I think that's something that we really probably should look at.
Here, actually, I just want to tell, first of all, we are so proud to have both Dr. Smita Das and Dr. Chandan Naik over here. And we're so proud to have these young doctors. They are here to give us all the information. And as far as the support group, as for my knowledge, there are many small informal support groups everywhere. But maybe this is the time. This is the time we have to come up with a formal support group. And yes, and if community is ready, there should not be any delay in this. And we can certainly look at this option.
So, Kuku, the best way to do it, let me speak, Smriti. I'm part of OSA Health and Wellness, and we have talked about this. We have been providing like a support to patients when they reach out to us. So if they go to OSA and reach out, click on OSA Health and Wellness and put a chat, this thing that, they want help. They don't have to write what is the cause, is it cancer, something, but they can just write that. So we are trying to make more regional groups so they can reach out because there's a difference in time zones, right? The different time zones. So depending on the regional group, they will reach out and then they will decide what's the type of support is needed, whether it's financial, whether it's medical, whether it's emotional, and it's there. So they are trying to formulate this. And if people want to join, they can tell us, and then we can include their names in those regional groups.
I agree, completely agree, Nitan.
There's Atasi Gantayat who has a question. She has her hand raised.
Yeah, hi, I'm Atasi. I'm a second generation, I guess soon to be senior. I'm getting pretty up there in age myself now, but I think, all this about support group and stuff is really great. In particular, I think it's important for the younger people to have that group. I know, obviously, people like my age group and young, and older have issues too. But I remember when I was a kid, it's interesting, like all of the issues that I faced being a second generation, probably the only Indian in my school, right? That was another problem, and all the stuff that I faced, we found out much later amongst my peer group that everybody was facing a similar issue and we all struggled so much on our own. So had we known that each other were kind of going through the same thing, it could have probably prevented a lot of pain at that time. I mean, because I think we all, I went through it. A lot of people us went through it. And so I don't know what the issues the younger people are facing now, especially because now it's obviously, you see a lot more Indians in school and all that. But, it's nice if OSA or whoever it is can provide a forum for younger people to address their issues.
Thank you, Tashi. And I can definitely relate to that. You know, growing up here in the 70s and 80s, only no Indians in my school. There's another hand raised by Ritanjali Patnaik.
Yeah. Hi, can you hear?
Ritanjali, we can't hear you. Ritanjali?
Can you hear me now?
I can hear you now.
Oh, okay. Thank you so much. I thought the whole session was really very well done, Dr. Smita and Dr. Chandan. Great that you, being the second generation, came forward and shared your perspective, and it's very helpful for everyone. One thing I do want to call out, the support groups and all absolutely needed, and I have volunteered in many different places, but one thing that each one of us can do is please look out for the telltale signs. Because we talked about people don't come out because of the stigma. They don't want to talk about the mental issues and all. If you do see someone sitting quietly, someone is not being the normal the person are, please reach out and be there for them. That is the first step that you can start to get them engaged and go to a mental health professional or something. So I think all of us as women, we are like, we have that empathy and we have that just the characteristic that can make people better. So please, if we all can do that, that would be great. And then of course the support groups and all, we can definitely look at building as well. Thank you so much for the forum, though. Very well done.
Thank you, Vitanjali. I think Chandra Mishra, she had something she was trying to say.
I was just saying the same thing, just even a body system, even if not the OSA or anything, because I have seen in my own eyes. The other thing, what she said, the other person, I'm forgetting the name. When my child was growing up, Seema, she was also the only one. And she will come and say, Mom, when I take out in the gym, I'm the only brown person. So they did go through, and we did not pay attention because in the school, they were the only one Indian student. So that generation, really, I can understand you, Smriti, we didn't know, and, they did a great job, but I sympathize. What I'm thinking that I am involved in the church and everything here to help because I'm a nurse. Even a body system, if something happens, they can call me or call somebody there. Even if not like in a organized way, that helps. That one moment, as you know, Smita, perhaps they're the doctors, they know. If they can go through the tunnel that time, then the suicide or so many things can be taken care of. I do agree with that. That is it. Sorry.
So what, Chandrapa, the system is difficult to do it in a big group, A. Number two is the person who is going to come has to trust you first. They cannot just trust a group. So this, if you keep it little anonymous, what we do is right now with OSA Health and Wellness, we support some patients. We talk to them, and this lady is it's almost 7 or 8 months. She just called me the other day. They've been doing very well. But they have to, it's a trust. We cannot just say, okay, you go and but you're paired up with this person or the A, B, or C.
Nita, I'm not telling that. I'm sorry. I'm not. What I mean is that तमे जो कहिला जे से माने ट्रस्ट करिया दरकार जतले तमर मेंटल डिजीज हेतिबो तमे ट्रस्ट भी करि परिबनी. So somebody has to be advocate, like generally here nurses or जो church or pastor, they are the one, just they can just say that such and such person. Then the other person, if she is a social, like social worker, a registered nurse who knows, or clinical psychologist, they can just hook them up. So what will happen, you may not do, but you work as a catalyst. Let the things goes on, but you just hook them up. And that has helped.
Individual case something. Regionally, so it has to be a regional group. It will be easier managed that way.
That's for sure. Yeah.
When you are in the trenches, when you're in the hole, it's very difficult to climb. But once they take the first step, Smita and Chandan, please correct me if I'm wrong. and you can add. So once they take the first step, then it's easier, right? But yes, OSA Health and Wellness has been thinking, we are doing in small ways.
But say first step ku kiye anibo Nita jo first step tame kahuch seita sie nije to ani pariboni tonu tar sang ଘର ଲୋକ ହଉ କି ସାଙ୍ଗ ହଉ ମୋର son suicidal ଥିଲା ସିଏ ମତେ କହିଲା ଯାଇକି ବଷ୍ଟନ ମତେ କହୁଛି mom this ନା ତୁ ମୁଁ ପୁଣି ବଷ୍ଟନ ଖୋଜିକି ତାକୁ କଲି ମାନେ it doesn't have to be ସେମାନେ କିଏ ଗୋଟେ ସେତିକି ବେଳେ ତାକୁ ଗୋଟେ ହୁକଅପ୍ କରେଇବା ଦରକାର କି ଏମିତି ହେଇଛି so ଯେତେବେଳେ ହେଇଯିବ then it will open up. Sorry.
Chandraba and Anita, I'm going to stop everyone just for a second. Because of interest of time, I see that there's just a lot of potential to do this, a lot of great ideas. And I think we could probably go on for hours with discussions. But so I don't know what the time limit is on this, but I do want to, before we go any further with our discussions with this, I do want to take a time on behalf of the Women's Empowerment Group of OSA to really say thank you to Smita and Chandan for joining us this afternoon. As you can see, your advice has been absolutely profound, very, very needed for this community. And again, on behalf of our group, super thank you for joining us this afternoon. Now, having said that, if you would like to stay on to continue participating in the discussion we're having, great. If not, I do understand if you have to leave. And I know the rest of us, we have a lot to discuss, so we can continue discussing. And someone tell me, I don't know what our limit is on this, or we can, after a few discussions, we can, decide about setting up another time to continue this discussion with more concrete ideas and more structure of development. I see that everyone here today is very, very passionate, which is great because there was a time as a community, mental health was never discussed. It was kept behind the doors. I mean, mental health, the word mental health means, like Nita fondly said, pagala. And no one wanted to talk about having a pagala in their family. And so we've come a long ways from that. Nitapa, do you want to add anything to that about and say thank you to our great speakers?
About India. So since having worked in India, I just want to say the perspectives. Indians mankor bahut besi mental health illness achieve. Most of the Indian, even physicians in my family think, oh, Indian mane puja karanti, so tankar mental health issue kichi nahi. Se puja karike jogo kari do tar mental health issue ठीक है जिबो. नाले से मंदिर रे जाओ कोटी झाड़ी दबो फुंकी दबो. And that's how the mental health this thing. But झाड़ी दबो that Debbie lagile and Kalisi lagile is a mental health issue. Even today. People are treated like that in India. So in 1980s, when I was in med school, there's this Sunday, very famous Sunday magazine who grew up in India will know, had a photograph of a boy and a girl in the streets of Calcutta. And the title was, 25% of these kids have major mental illness. Recently, just in the news, just before, the day before our Indian budget was passed in the parliament, there was a vaccine rollout seminar in Delhi. A young physician, Dr. Maheshwari, stood up. Instead of talking about COVID vaccine, she said, Delhi is the suicide and depression capital of the world. So more money needs to be allocated for mental health care. So Indians and Indian parents ko achi, we just think that we'll bury our hands like ostriches and everything will go away. And our first generation Indian parents, we didn't know much. We had to succeed, we had to survive, basically. It was a survival instinct. So, whether we listen to our children, whether we should have thought about putting them in schools where they're more like them, that was not a thought, which we have choices now, I think. But having grown in India, I grew up in all over India. So more, we were in a co-education school, English medium, which is totally different from the way my mother was raised. But my mother did one thing. When we came back from school, she will be sitting in this long chair, and we will just sit, all three girls will sit and tell us, we'll just vomit out their whole days, whatever happened. She knew all her friends. Later, I found out that she may have listened only 50% of the things, but that listening helped us heal and deal with the situation, because we had also a lot of issues as adolescents. And the society was changing in India also. That's all I have to say. So all we have to do is listen to our children. We don't have to advise them. Jadi, when they come back from school, I even tell my Latino parents, be there when they come back from school, they're tired, that's when they want to talk. And just be there to listen to them.
And also no expectation.
Yes.
No expectation.
Indian parents and no expectations.
Thank you, Mita and Chandan. I'm very, very happy to listen everything. But you cover a lot. But you know what? As a OBGYN, I see a little different aspects of mental problems, which in India, they don't think that's a problem. First thing is the postpartum depression. So many things, happens, and then, they have been the young mother or recent mothers, they will explain to you so nicely, so vividly, and you think they're sattare pagala emti kon houchanti. Kintu you know what? Over there, I have also seen also, because I did my residency over there. I did work in India too. Actually, I may be city ignore korthule gudaka. I mean, it's such a good idea to keep up that. The first questionnaire is the depression. Asile postpartum checkup, we have to ask first. And then the second thing is a postmenopausal depression. Kete problems hochi. Over there, this, eta hejibo, seta khaidele, seta hejibo. Kintu yes, khaidele hejibo. Kintu some need some help. So, I just wanted to talk to you about those, because in these few little hours, you cannot cover so many things. But, I'm so happy that you did very good job, ma. Okay, bye-bye.
Thank you.
Thank you.
I think, Smita, do you have your hand raised?
I wanted to take a minute. I imagine this conversation, there'll probably be a part 2 and the discussions. I love this. I wanted to, before everybody jumps off, because I know people are leaving, I wanted to thank the organizers, and I'm going to read everybody's first name and last name because we all have similar first names. So Nita Mahanti, Sujata Patnaik, Devanshi Chaudhary, Manaswi Misra, and Smriti Panda. I think, I just really, really appreciate you're putting this together, inviting us, and Dr. Chandan Nayak, great to meet you and to do this. And then finally, everybody who's here, I mean, it's so heartwarming for me to see my mom, all the other moms in my community. Mama, the comment you just made about postpartum and women's depression, that's a whole talk. That's a whole, multi-day seminar that could happen. Like, on all of you giving attention to this, thank you. Thank you for making this a priority for yourself and for your loved ones. And from the bottom of my heart, thank you.
Thank you.
Okay. Thank you.
Lisa, do you have your hand is raised? No? Okay.
Can I say something?
No, I saw another hand raised. Lisa's.
Okay.
It was a mistake.
Okay.
I haven't known.
Question about postpartum depression. There will be second part of this mental health seminar, where we'll be talking more about postpartum depression, menopausal symptoms, and also other issues, domestic violence. So say bisara haba, but I want to just say something funny or whatever, informative. Do you know how the word gossip came about? I think Smita and all know, right? So in Middle Ages, when a young girl went into labor, they invited the women folk of that village. And they knew about opium and sugary drinks, so they gave the lady, young girl, sugary drinks and opium and recounted their own stories of labor. These women also came back later to help this young mother raise, take care of her baby. and helped her through postpartum depression. So it was sibling of God, sisters of God. Over time, gossip became gossip.
That's
Interesting.
interesting.
Very
So,
interesting.
but just so you know, I mean, we are definitely the Women's Empowerment Group. We are looking to putting on several more seminars. And again, we realize this is the very first in the series for mental health. We will be continuing to pursue additional seminars. Part one, I know this is part one. We'll have part 2, 3, 4. Again, we will be doing it based on the demands of the community. In addition to that, we have some other exciting seminars coming up. We have another one coming up on Odisha development sometime in April. We'll also be dealing seminars. We'll be doing seminars on domestic violence. And of course, that one being so broad, we will be doing it in multiple parts, addressing various parts in situations of domestic violence. So we're really happy that all of you were able to take time out of your busy schedules on a Sunday to join us. And again, our seminars are only as powerful as the audience that joins us. So again, thank you, audience, for joining us today. And please spread the word, and please advertise our future seminars if you've really enjoyed this. Again, we want to spread the word about what we are trying to achieve. I'm having said that.
Kuku wanted to say something.
Yes.
I guess, she has been asking.
No, that's okay. That's okay. Let everybody share their thoughts. It's okay.
No, Kuku, go ahead and say. I just wanted to, before I see people were leaving, so I just wanted to put in a little plug for what we're doing.
Do we have more information about the future seminars?
We're in
Please
the
go ahead.
process of planning them. We've set some preliminary dates. We kind of have already set somewhat of what the next seminars are going to be up until July. Sujata, maybe you can speak more to that.
April we'll do on actually Odisha development, and after that we have on domestic violence, and then next we have on women's health. This next 3 months, this is how it is scheduled, and then we'll be having part 2 of each of the seminar that we are doing. So throughout the year, every month, at least once a month.
And also parenting, right? There was one on parenting.
One on parenting also, Rajeshri, if I was going to. So we're trying to stay busy and bring information to you guys.
Great.
Thank you, Smrit. Thank you, Sujata, and thanks, Nitani, for this wonderful forum, for arranging this one. Also, I want to tell everyone that talking about a support group is such a wonderful idea. And again, I will repeat the same thing. Regionally and locally, we have definitely we have some informal one, but we have to make it, make it as a formal group everywhere. Looking at the demand, and I'm seeing that everybody will love to have one. At the same time, I want to tell everyone life definitely is moving for good. And currently, these 2 years, we have added 3 major forums. One is our health and wellness forum, and the second one is women empowerment. That's a new one in history. And of course, another one, very important one, as Atasi was mentioning, we have a very vibrant youth team. So looking at all these 3 teams, I think they will, communicate with each other, and they will have a bond. I think there comes the support group. So each part of the community we are kind of trying to reach through our women, through our youth, and obviously we are very proud to have OSA Health and Wellness. You can believe throughout this pandemic time how many times we have reached out to them in various different situations, and day, night, 24 hours, they will be there to reach. I had called myself like 1 a.m. in my time. For some reason, like somebody reached out to us and we called. That means East Coast, it will be 3 or 4 a.m. and they are there to help us. So why I'm mentioning this? So instead of thinking about or taking time to have to create more support group, why don't we start right away, take advantage of these current teams like women empowerment, our health and wellness, and our youth team. Then here we go, and we'll support the community. if anybody need anything, try to reach out to us, and maybe we'll provide more information on how to, even if OSA currently has a 24 hours hotline, hardly we see anybody use that. So maybe we'll bring more numbers or to make the original numbers to make everybody comfortable to reach out to us. Thank you, everybody. Thanks again to our Women Empowerment team, and you are awesome. You are the team I'm seeing anytime I ask like, okay, what's our plan? And they come up with not one, but 10. So you, you are keeping current executives on top of our list. So thank you again. Thank you, everybody.
କହିବାର ଥିଲା ମାନେ ଆମର ଏଇ ୱିକ୍ ରେ ଦିଟା ଟକ୍ କନଜିକ୍ୟୁଟିଭଲି ହେଇଗଲା. If we can not do that, that will be great, because କାଲି ବି ଗୋଟେ ଟକ୍ ଥିଲା, ଆଜି ବି ଗୋଟେ ଟକ୍ ଥିଲା. So I think next time if we can be watchful, that will be
right. So that was yesterday's was our region
chapter.
Chapter 1. So when it happened, the chapter happens most of the time. We keep we know what's going on in other chapter, but not necessarily all the time. And if it's already a pre-made one, prepared one, or a scheduled one, we don't want to. Unlike women, OSA women empowerment, what's going on, we directly. I mean, we are the first one to know. Okay, these are the schedule, and so yeah, maybe in future when chapter they do something, they have to connect to the national. So.
Yeah, yes. Sorry, Coco. I wasn't part on both of them. And actually, we did try to change it. I did talk to Sujata, but I mean, I understand, and I'm really happy that people were interested to attend yesterday's also. That's a good point, that we really need to, even if it is a chapter and national, we have to be careful not to have too many seminars in the future. Thanks.
Thank you, Jitani.
Thank you.
Hi, I just wanted to quickly say something. First of all, huge thank you to Dr. Das and Dr. Naik for this very insightful conversation. I myself part of OSA Youth, as well as I am a college student. So learning about kind of balancing that school life, social life, as well as during the middle of a pandemic has been definitely a struggle. I think a lot of youths would benefit a lot from a conversation like this. So if we could organize something like this for the youths, that would be truly wonderful, because I know today, just from the hour or two that we spent here, I feel like I really have a roadmap for at least the next month of what I need to do to work on my mental health. So thank you so much.
Thank you for joining, and thank you. I think those are words that resonates with a lot of parents of college students.
Smita, Chandan,
tell us what you want to hear.
Seminar for youth, they will really be benefited, I think. So
yeah, so we would. So why don't you all tell us what you want to hear from us? Then we can address that. That will be easier for them.
Great.
And more productive.
Ananya.
Yeah, we'll hook it up.
Definitely, we'll work with all of our forums to make sure that this happens.
So you tell us what you want to hear, both
Definitely.
from OSA Health and Wellness, and from this women empowerment, and we'll make it happen. We have a lot of other speakers, so do not worry. There's no dearth.
That is wonderful to hear. Thank you.
We have a very resourceful community, and I think it's amazing when we start tapping into them. And every time we've asked someone to come speak, they've always been more than willing. So it's high time we did start tapping into our own.
I just want to thank both the speakers. They were so nice and accommodating, I must say. I just reached out. I did not know Dr. Chandan Naik. I just called him one evening when he was driving back home, and he immediately agreed. And same thing with Smita, who of course I know, but I know she's extremely busy. And she said, yeah, she'll do anything. She was very flexible about timing, about what she says. And thank you, Smriti, for being such a wonderful moderator. And I want to thank two young Oriya High School seniors, Namasri and Debanshi, who did the flyers.
They've been amazing.
Yeah.
Yeah.
Manasvi is here. Akki Sethi. Dekhuchi mu Debansi ko dekhuni.
Yeah, Anasi is we call Chiki. Now she is grew up partially in Michigan, so we do claim her. So DC can't just.
Wonderful, wonderful to see our second generation like this. I'm so proud of them. Smith, I saw her when she was a little girl, and now I see. And one thing I noticed that if you reach out, they are really. We just have to reach out. We are thinking, oh, they won't, but they will make time. I know that my children will make time if somebody will reach out. Not mom for show me this, show me that, but things like that. I know that they will be glad to come and help whatever way expertise they have. So the younger generation, please reach out to them and get the advantage. You all have them. And then of course us. Very proud of all the young people and everybody. And thank you for giving me opportunity to be here.
So we'll wrap up.
Okay, bye.
We should wrap up. So again, this was, like I said, just the beginning. We will continue. Please stay tuned for additional flyers about additional seminars and workshops that we will be doing. Thank you, everyone.
Thank you. Thanks for having us.
Bye-bye.
Bye.
It was wonderful to see
Bye-bye.
all of you.
Bye.
Yeah,
Bye-bye.
Now you will get a lot of questions and calls.
Okay.
Nice.
Bye-bye.
Hi, Pia. Hi, Pia.
Bye.
Smriti, I'll call you.
Okay.
I can end this one.